Hi everybody, I'm Nicola Mendelsohn and I'm the co-administrator of the group living with follicular lymphoma. Today the group is over 1,800 people strong. It hasn't existed for very long, so we are incredibly excited to be doing something new and different today. Today I'm being joined by Dr. Robert Marcus. I'm absolutely thrilled to have you here in the studio today. And he's going to be answering questions that you have given and also questions that you can continue to give as we go through this interview now. He's asked me to stress that he absolutely can't give individual patient advice, and so all of the advice here is very much specific to meant to be generic, maybe to share information that you might not have been aware of, but that's the spirit which this session should be taken into. So given that we've got people on now today from all over the world, I wanted just to give you a little bit of a background as to why we're thrilled that it is Dr. Robert Marcus here with us. So I'm sorry and to spare your blushes, but you did start in the UK where you qualified in medicine in 1977. You underwent postgraduate training specifically in haematology in the UK. And then in 1987, 10 years later, you went to Cambridge. And you spent a lot of time here in a consultant position working in bone marrow work on transplants specifically. One of the things that Dr. Marcus did was to establish in the UK the London Lymphoma Forum and also something called the National Post-ASH Highlights, which was the annual conference where people come together in this area of medicine. But that's not enough. He does a lot more too. You're a medical advisor to the Lymphoma Association, to Bloodwise, and the Vice President of the Leukemia Care Society, all very important in the UK. Of really interest to everyone in the group is the fact that Dr. Marcus has actually led a number of innovative clinical trials that have actually transformed clinical practice. And he's been the chief investigator instigating the use of new agents in lymphoma. And you also chair in the UK the low-grade lymphoma subgroup of the National Cancer Research Institution's Lymphoma Committee. And if that's not enough, he's contributed to over 200 articles and papers, co-edited one of the standard textbooks on lymphomas and myeloma, and contributed to the 2016 edition of Postgraduate Haematology and the Oxford Handbook of Clinical Trials. So, Dr. Marcus, I'm absolutely thrilled that you are here. So we've had lots and lots of questions. People wanted to ask you lots of things. So I think that shows that there's a burning desire to know. And what I tried to do with my limited medical experience is to group them together into kind of 3 or 4 key areas. So the first area I'm going to touch on is treatment. And some different things. There's a lot of questions around rituximab. And one of the questions here was, do you ever use rituximab alone for its first treatment? Or do you always use it in conjunction with another or some type of chemo?
Standard practice in the UK has been to combine rituximab with chemotherapy, but that's not the case all the way around the world. There's been a number of trials in the Nordic group and also in Switzerland where they've used rituximab as a single agent, often followed by maintenance therapy. That's not common practice here, but there's no reason why patients who've got symptomatic disease, who need therapy, but who've got low volume disease, there's not much of it, but they've still got symptoms, or they're very frail or elderly, couldn't benefit from rituximab induction therapy followed by maintenance treatment, as is used in Switzerland and in the Nordic countries.
Okay, so there's a question specifically on maintenance and feelings towards maintenance, Rituxan versus following R-CHOP. So if you have gone through the whole R-CHOP, should you be doing, what do you feel about Rituxan?
Well, I think that the data is quite strong. There's one very big randomised trial, which was the PRIMA trial, led by the French group, which did actually demonstrate there was an improvement in what's called progression-free survival, so time without therapy. There's no overall survival benefit suggesting that patients can still be treated when they recur, but you're free of disease for longer. There's another German trial which shows the same thing, and there's also 2 other retrospective population-based studies which also suggest that rituximab maintenance is beneficial. But there's no overall survival advantage in many of these studies. It just keeps you free of disease for longer, and you have to always weigh up toxicity against benefit. If patients have no symptoms of disease at all, or no symptoms rather of treatment, they don't get infections and have no other problems with the rituximab maintenance, I think on balance it's a good idea to have it.
Okay.
But if patients' immunoglobulin levels go down or they get infections or other complications, there may be no reason to actually continue to give it. So it's always a question of balance, of keeping the disease under control versus side effects.
Okay, so it's about quality of life is something that you always are considering at each stage.
Absolutely.
And there's been a few questions that people have asked around, you know, if you've already been on watch and wait for maybe 2 or 3 years since diagnosis and it's a slow progressing disease, what would your recommendations be with something like that? If someone had no symptoms and were maybe, stage 2, grade 3, something like that?
There was a feeling that watch and wait will be superseded given the fact we've now got comparatively non-toxic effective treatments. But there's a big retrospective study published last year in the British Journal of Haematology, which once again demonstrated there's no long-term advantage in having treatment if you don't need it. And I think that remains current practice, that if patients are asymptomatic, there really is no evidence that the disease turns anything nastier or is less responsive to therapy when it requires treatment. So I think watch and wait is still legitimate. Okay.
So big question on maintenance versus non-maintenance. I really want to drill down to that. Do you recommend it? And if so, what length of time are you recommending it for?
We do recommend it in general terms. We recommend it following the PRIMA trial protocol, which is every 2 months, every 8 weeks for 2 years. And I think it is overall beneficial. We have to keep an eye on patients, though, and I think if they do start to suffer from infections, other problems, if their immunoglobulin levels go down and they start to get sinus infections, for example, then I think there's no reason why it couldn't stop, especially if patients have had a negative scan at the end of their induction therapy. Okay. Now, a lot of places in the world have got access to PET scanners, and if the PET scan is completely negative, there's no active disease at the end of induction therapy, then the benefits of maintenance therapy are there, but they're not as high as if the PET scan's positive. So I think there we have to weigh up once again any side effects versus any benefits.
Okay. So again, back on the rituximab maintenance, is it worth the risk of infections if with every treatment you get neutropenia?
No, I don't think it is. Okay. I mean, neutropenia is comparative.
Can you explain what that means as well, just to make sure everyone knows?
Neutropenia is when the neutrophil count goes down. Normally, that's associated with chemotherapy because that affects normal bone marrow function. Rituximab rarely, but it's well described, can cause neutropenia, usually fairly short-lived, but it's usually an autoimmune phenomenon where, if you like, the body starts to attack its own white blood cells when you have rituximab. Now, if that starts to happen and the neutrophil count goes to very low levels and patients start getting infections, once again you have to weigh up risks against benefits. And in that circumstance, I would probably stop the rituximab and say we could follow you up without treatment and then treat again at the time of any recurrence.
Okay. So BNR seems to be the general standard for first-line treatment in FL, but is there something similar for when it first returns?
Well, I mean, we'll take that question in 2 parts. Okay. First of all, the bendamustine rituximab data was updated this year at Lugano. And
explain what Lugano is.
Yeah, Lugano is a very big, is the International Congress on Malignant Lymphoma. It's in a lakeside town in southern Switzerland called Lugano.
Sounds very nice.
It's very nice, but except you walk along the lake and then you're plunged into a windowless basement with PowerPoint. So after that, it's not so fun. But actually, it's quite nice. It's a lovely environment, and almost everyone who can go does go. Right. And this year, the data was updated. The old bendamustine rituximab data from Matthias Rummel was updated. And it suggested that those patients who'd received bendamustine rituximab, there were a lot of patients who had not relapsed by 10 years, and that was without maintenance therapy. So that's quite interesting in the context of what we were saying a few minutes ago, that in general terms we recommend maintenance, although we have to weigh that up against any toxicity.
So that's great breaking new news then.
Yes, I mean, it's an update. It's a long-term follow-up data from that study.
Excellent.
So I think, yes, in many parts of the world, bendamustine rituximab would be regarded as first-line therapy. And what you do at recurrence is a very big question. And I think it very much depends on, first of all, the duration of that remission. Secondly, how fit and well patients are. Are they fit enough to have stem cell transplant, for example? And the main thing, of course, is how long that remission has lasted for. So I think there are a number of factors which you have to take into account when considering what you do at the time of recurrence.
Great. So this is a question to the people that are listening to this. If you want to ask a question, please type and ask a question just as you would in the normal comments area, and then I can pick it up and add it into the questions as well. A different question on how if you're on watch and wait already, Do you recommend that patients should be CT scanned while you're watching and waiting? What's your policies on watching and waiting? What's the decision making?
I think that if you've got palpable disease, in other words, a disease you can feel, then it's easy, because normally the size of glands you can feel corresponds to the size of glands you can't.
Right.
So that normally this disease grows in most places in the same sort of way.
Right.
There are one or two exceptions to that. In general terms, that's true. So then I think it's legitimate, having scanned the patient, say, once at the beginning and perhaps a year later, to assess tempo of disease. It's reasonable to assess by clinical examination in the absence of symptoms. The difficulty comes if the patient's only got disease inside.
Right.
And there you've got to weigh up the risks of long-term scanning. A patient in their 30s or 40s, how often are you going to scan them? CT scanning and PET scanning do involve a certain amount of radiation, and therefore there may be some minor but definite risks attached to scans every so often for perhaps 20 or 30 years. And that I think you have to weigh up. MRI scanning has no radiation, but there's limitations in accessibility, and it's not quite as good in assessing where disease is. So I think that one has to be sensible about these things. If the patients are without symptoms and you've established that over a period of 1 or 2 years the disease is very slow growing, or that the size of increase or the rate of increase of any glands on the outside that you can feel, in the neck or under the arms, is the same as the rate of growth inside, then it's reasonable not to scan. Okay. But if you've got a patient with, let's say, a 3 or 4 centimetre mass only in the abdomen, or only in the chest, you might want to scan them over 1 and 2 and 3 years to establish tempo before being happy and comfortable you can follow these patients up clinically.
Okay, so what I'm hearing from you, and I'll put it back in my own speak, is that there's no right and wrong answer to really any of these, because the disease is so different in so many people. And that if you can feel it, actually, that's quite a good thing, because you can get an indication as to what's going on in and out of the body, so you might not necessarily need to scan quite as often. You're very much of the view that you're in this to treat people for the long term.
Absolutely.
And therefore, there was a question on radiation exposure. How often do you recommend? You're very much of the view as not as often as, some might think. Although there is the mental anguish issue, isn't there, that people struggle with. I see a lot of people in the group talk about the worrying, watch and worry. I just want to know what's going on. Help me on that a little bit. It's
difficult, isn't it? I mean, it's very difficult to tell a patient when you first meet them, yes, you've got cancer, and no, we're not going to do anything about it.
Yeah.
But I think there are a series of hematological malignancies like that. Chronic lymphatic leukemia is another one. But there you often have a high white cell count, you can monitor that. In follicular lymphoma, especially when you've got patients who've only got glands enlarged in the chest or abdomen, it's difficult to actually reassure them that you are monitoring them carefully. But in the absence of any symptoms at all, any cough, any shortness of breath if you've got glands in the chest, or any abdominal pain or bloating in the case of glands in the abdomen, I think once you've observed a patient over a period of 2 or 3 years, and you've scanned them perhaps at the beginning, after a year, and after 2 years, and you've seen the tempo, the pace of increase, then I think it's reasonable to follow such patients up clinically in the absence of symptoms.
Okay. So we've got a question coming in live, and there's a whole load of questions in this area, which is all around sort of the holistic well-being. So if people are going to be on watch and wait, and they, we're going to be looking after these patients for a very long time, there's a question here about how you feel about supplementing with D3 and the research that claims worse outcomes for patients with low vitamin D levels.
I think there's some data on the effect of low vitamin D levels in patients having chemotherapy.
Right.
I'm not sure you can actually extend that into saying that if your vitamin D levels are low, the disease will progress more rapidly. But I don't object to dietary supplements. I think maintaining a healthy diet is very, very important. But what I find sometimes remarkable is that patients who've got lymphoma, or you've treated them for lymphoma, and still smoke, for example, or still actually have a very unhealthy lifestyle. So I think there are additional things that one might do to improve your well-being. But I think looking at the simple things, not smoking, not drinking too much alcohol, maintaining good control of blood sugar, cholesterol, and blood pressure, all those things in the overall sense are beneficial.
Okay, so I've got several questions, and I want to make sure that everybody got their question. So do you think lifestyle factors affect remission times?
Not that I'm aware of, no.
Okay, and that's because there's no data been done. So you're answering that based on research and data as it exists. But your general point here is, why wouldn't you embrace a more healthy lifestyle?
Exactly.
Okay.
I mean, after all, if you're going to have this disease for many, many years, you can take the view as, oh, well, I've got cancer, it's going to shorten my life. But actually, you're better off saying, actually, this is a disease which may not in any way shorten my life. Yeah. I should live a healthy life during this period.
Again, because I want to give I'm going to keep asking these questions in a random different ways. So are our chances for longer, better outcomes increased by not having any alcoholic, and it's ever written in caps, or can we have a glass or two of wine every other day?
I don't think there's any evidence that low level consumption of alcohol is actually in any way detrimental, as long as you're not giving yourself enough to affect your liver. So I think the standard advice should be followed. I don't really think there's any evidence that low level alcohol consumption affects the rate of recurrence or rate of progression.
Right. So for someone who's feeling well, do you place any limitations on physical activity such as running or heavy cardio? It was a big conversation in the group that somebody had been told once that they shouldn't do any strenuous cardio activity.
I don't think there's any evidence for that. I mean, I think that obviously you've got a patient who's on chemotherapy, and some of the drugs, as you know, can have a detrimental effect on the heart, then I think you have to monitor that carefully in that context. But if patients aren't having treatment and are feeling well, there's absolutely no reason why they couldn't follow their usual exercise programs, in my view.
Okay. Specific one on diet and sugar. People talk a lot about sugar and cancer. Do you think a low sugar, low GI carbs diet alongside an alkaline diet will starve out the cancer's ability to reproduce? Any evidence?
I don't think there is any evidence. And I think, sadly, cancers take what they want from you. And I don't think taking your blood sugar down or your sugar input down will make a difference to the actual growth of the cancer, although obviously it has an effect on your body mass index and your risk of type 2 diabetes.
Okay, so the last thing we want is you dying of diabetes
exactly.
if you've got this. Would an alkaline diet assist the body in supporting healing with or without medical support like chemo?
That I wouldn't be prepared to comment. It's not an area of my expertise.
Somebody's asking a very specific, can you consume pure natural RCC stevia?
I honestly wouldn't know.
Okay, I'm putting the questions because these are the questions that matter to people.
Okay.
Big question here. The person's writing in saying, thank you for being here, Dr. Marcus, and thanks to me for pulling all this together, they say. They're beyond grateful for the opportunity to ask you questions. It's a big question. Do you believe a cure will be found?
I think there might be, but I'm not sure it matters in a sense. Because if this disease can be controlled without it affecting your life expectancy, do you need to cure it? And that's I think we're moving not away from the notion of cure in certain cancers, but towards the notion of long-term control. So, for example, in chronic myeloid leukemia, a very different disease, we used to only be able to cure it with bone marrow transplantation, a treatment of high toxicity and not without risk. Now we suppress the disease with a drug called imatinib and its successor molecules. We don't cure it. If you stop the treatment, it will come back in the majority of cases.
Right.
But you can suppress it, usually for many, many years, and actually not affect life expectancy by actually treating with imatinib or one of its successor molecules. Now, to be facile about this, you can say we don't cure blood pressure. We give you pills, and when the blood pressure goes down, we carry on. And if you stop the pills, it comes back, and the same with diabetes. So I think in some areas, we're moving away from the notion of cure to long-term suppression with long-term treatment. Now, that doesn't apply yet to follicular lymphoma, but I think we've got to start thinking of cancers in a different way from, oh, we're going to destroy it with surgery, radiotherapy, and nasty chemotherapy, and then it will all go and it won't come back. I think we've got to think of things in slightly different terms, of long-term suppression of the disease such that it doesn't interfere with your way of life or life expectancy.
And so that's a very big ask in terms of patient mindset, because I think when you get told you've got cancer, it's almost like you're going to live or you'll die. We'll cure you or you'll die. And this intermediary way that you're talking about of just maintaining and live with it, is, you know, it's one of the things that you see that patients really struggle.
Yeah, but you have diabetes. I'm not going to cure it.
But I don't think the same association. I think this is to do with the word cancer.
Yes, but if you have high blood pressure, you're at a very high chance of having a stroke. So if you control it with these pills, then actually control this disease for many years. It doesn't ever go away completely because you can't stop the pills. And we should be just beginning, I think, to think in terms of certain cancers in that way. Certainly chronic myeloid leukemia. There are certain patients with chronic lymphatic leukemia now receiving ibrutinib, in whom the disease is suppressed very long term. And again, we're not curing it, but we are suppressing it. And if we can suppress it for the natural life expectancy of the patient, we don't need to do more.
Brilliant. Question here about pregnancy. Does pregnancy increase the risk of relapse in patients who are currently in remission?
Not that I know of. There are certain associations with your body's own immunity controlling the disease in certain cancers. And pregnancy, of course, is an immune suppressed state because of course, the mother tolerates the fetus. So in theory there might be, but I'm not sure of any evidence in follicular lymphoma that it increases the risk of recurrence.
Okay. There's a question around going back on when you're actually having treatment and you're having something like R-CHOP. Any particular supplements that can help with that?
Not, again, that I'm aware of. I think maintaining a good nutritional status is important. I think in some respects, more important than the nutritional supplements is the reporting of any side effects of treatment as soon as they occur.
Okay.
For example, older patients who may have diabetes, for example, and damage to the nerves, may get more tingling with vincristine, and I think reporting these side effects at an early stage may enable the doctor to adjust the medications appropriately.
Okay, so the key message there is you're not opposed to these things, but make sure you keep very close dialogue with the nurse or the doctor that you're working with, and make sure. And I think anybody that's working with cancer, has cancer, is super aware of anything to do with their body. So just tell, because it could be to do with some of the things that you're taking on the side. Again, people keep asking, tell us, does multivitamins help during treatment? Can they impact the effectiveness of the drugs, which is...
Again, not that I'm aware of.
Okay.
And I think as long as there's no actual vitamin deficiency, I'm not aware of any good evidence that actually dietary supplements actually augment the effectiveness of chemotherapy, so long as you're well and have a balanced diet. But that's very much the conventional medical approach, I think.
Okay. Turmeric comes up a lot.
Oh, yes.
Turmeric and curcumin tablets.
Yes.
Are they good? Do they promote cell growth for the immune system? Will they not also promote growth for the cancer cells as well?
I don't know any evidence in follicular lymphoma. I know there's some evidence in multiple myeloma, but I'm not sure anyone's done any proper randomised trials to assess response and assess duration of response. In follicular lymphoma, I don't think there's any strong evidence that this is, or any evidence that I've seen, which actually suggests that that kind of supplement actually suppresses the tumour, or indeed, or makes it grow any worse.
And there's a similar question that I'll follow up on, which has been in the group as well. There's been talk about extreme dieting, even fasting, as a way of reducing growth of tumours. Do you see any evidence of that?
I don't, and also intuitively, often patients with cancer lose weight, which suggests that as they lose weight, the cancer itself is growing, and doesn't actually prevent it from growing. It takes what it wants. And actually it may deprive you of nutrients, so there's a good reason for actually maintaining a good diet and maintaining appropriate nutrition. But I'm not aware you can starve the cancer. I think you can starve yourself, but the cancer will still survive.
All right. So there's a question from Lisa live, which gave us a name on this one. And forgive me, everyone, because I'm not a medical person getting some of the wording wrong here. But what's your feeling on, is it Bexar or Zevalin, and what are the studies on this?
Oh, yeah. Well, this is radioimmunotherapy. This is when you add an antibody, you link an antibody to some radiation.
Yeah.
And there are two drugs, Bexar and Zevalin, which were linked to different radioisotopes. They were given as injections, and they targeted the radiation to the tumour. Now, follicular lymphoma is a very radiotherapy-sensitive tumour, so it makes sense, if you like, that if you can target the radiotherapy to the tumour, then it's beneficial. Now, there's some studies, we did some studies here many years ago, and there were a lot of difficulties, practicalities of labelling, of actually linking the radiation to the antibody and bringing about targeting. So there's a lot of pharmaceutical issues about that. And there are two studies actually updated recently at this big international meeting suggesting it's highly effective. It's both Bexar and Zevalin can be very effective in actually maintaining remissions in patients. The problem is the technical element of it and actually getting the linkage from the radioisotope, which is the actual active element, linking that to the antibody and delivering it. And I think many companies didn't find it was a very cost-effective approach, even though actually it's actually very useful theoretically and in these trials. And it was felt not to be superior to rituximab, which is much easier to deliver. You don't need to do complicated technical things in the pharmacy, linking radiation to the antibody and then injecting it, you can take an antibody off the shelf. But in theory, I think that radioimmunotherapy is very valuable. There are a couple of trials suggesting benefit. We're also moving a little bit on from that now, of antibodies linked to toxins, not to radiation, because lots of radiation protection issues surrounding the use of radioimmunotherapy, but not so many in patients where you give them immunotherapy linked to toxin. So toxin-linked antibodies are perhaps a better prospect than radiation-linked antibodies. Okay.
Question back on rituximab come in from the audience. Can you damage, this person's heard that it can actually damage the immune system permanently. Do you believe that to be true?
Well, no, there are some patients who have low immunoglobulin levels, low immune levels, long-term. They're a small number, but that's definitely the case, that small numbers of patients do have long-term, what's called hypogammaglobulinemia. Their immunoglobulin levels, and therefore the immunity, can be affected long-term.
Okay, but it's a small number.
It's a small number, but that's why, in terms of maintenance treatment, one has to be cautious and monitor immunoglobulin levels and weigh that against the benefits in keeping people in remission for longer.
Okay. Question on monitoring. Somebody's asking, can blood work alone be used for follow-up, for monitoring, and allowing for any PET scans when something doesn't look right, or back on the scanning? So it's can you just use bloods, or is yearly scan mandatory? Some people in the group are having scans quarterly.
I think most of us now would say that once you've established a patient's gone into remission with either immunochemotherapy or on maintenance, if they're asymptomatic, you've documented that they have a negative PET scan or a negative CT scan, then there's little point in scanning patients regularly outside clinical trials.
Fine.
Now, in terms of blood, at the moment we can't do anything routinely, but there are techniques which are just beginning to enter clinical practice, some in actually solid tumours like lung cancer and breast cancer, called cell-free DNA. And that's where the tumour cell breaks down and releases some DNA, some genetic substance, into the blood, and that can be detected. It can be detected in lymphoma, and it may be a way of assessing whether patients are having a rapid response if it disappears quickly, or it comes back. Not yet entering routine practice, but I will foresee the day in the not-too-distant future when we'll be able to use techniques like that to assess whether or not patients are in remission and whether the disease is coming back, obviating the requirement for scanning.
Okay. What do you think about the possible role of, I have no idea you said this, ibrutinib?
Ibrutinib?
Yeah, that one.
Well, there are a whole series now of non-chemotherapy agents which interfere with the signalling pathways in the cells. If we go back to the original idea of killing tumours, then we were giving what's called cytotoxic chemotherapy. That affects the DNA in the nucleus and the way it replicates. Now, after that, we've had antibodies which bind to the surface of the cell and recruit the body's own immunity to destroy the tumour, or they actually have a toxin linked to them and actually kill the tumour that way. But more recently, we've had treatments within the cell which are interfering with the signalling pathways in the cell. So the cell, to grow, will have certain signals which it receives from the outside, which transmitted through the cell itself into the nucleus to try and improve replication, to try and make it duplicate or replicate. Now, those signalling pathways are critical to cell survival. And for the first time now, we're seeing some drugs which interfere with the signalling pathways, and ibrutinib is one of them. Another one called venetoclax, which actually affects, again, a signalling pathway within the cell. I think they're potentially very important, but as single agents, they don't seem to work terribly well. It's when they're combined in doublets or triplets they have the major impact.
Okay.
So to take you back to ibrutinib works extremely well in two kinds of lymphoma. One is chronic lymphatic leukemia, where it often can suppress the leukemia long term. And there's another disease called mantle cell lymphoma, a rare type of lymphoma, where again ibrutinib can suppress the disease in the long term. But in follicular lymphoma, for reasons we don't quite understand, as a single agent it's not quite so effective and will need to be combined with other drugs.
Is it true that one can be cured of follicular after an allostem cell transplant?
That is true, yes. And I think we are offering it to patients whose disease comes back early, who've got quite an aggressive...
And early means?
Well, within a couple of years.
Right.
I think it depends on how quickly a disease comes back, how aggressive a disease comes back. Yeah. After all, you can still do a watch and wait policy a second time around if the disease is actually growing very slowly. But allograft is, or allogeneic transplantation is curative, except one has to accept an early mortality of around 15%, because the side effects of the transplant, including infection and something called graft versus host disease, can actually induce the premature death of a number of patients. So we do discuss allogeneic transplantation with patients who are fit, who are fairly young, have a matched donor, but they have to accept there is a risk, an early risk, of not getting through the procedure.
Okay. So if R-CHOP was the first treatment, now it's R-Bender, what would be the next thing if you were to relapse?
Well, it depends. I think, again, it's sequencing. If you've had bendamustine first line, you can give it again, although it may cause suppression of the bone marrow. CHOP you can't give again because of the anthracycline, the H, the hydroxydornamycin or doxorubicin can have adverse effect on the heart. So you go around a cycle of different drugs again, or you might find there are novel agent combinations. So, for example, ibrutinib in combination with other agents, or lenalidomide, or venetoclax. These are some of the non-chemotherapy agents which are entering clinical trials now and may start to form part of routine practice in years to come.
Okay. So that's good because that means it's not a definitive one. There's lots of different things you can think of and consider.
And I think the important thing at relapse is, first of all, does the patient need treating at all? Can you adopt a watch and wait policy? Okay. Can you offer, say, radiotherapy if it's localized disease? Right. Are you certain it's not transformed into high-grade lymphoma? There's an approximate 3% chance of low-grade follicular lymphoma transforming into diffuse large cell lymphoma every year. It's a small chance, but it's not nil. And therefore it's important that at a relapse, especially when you're considering therapy, that you should actually re-biopsy the lymphoma to make sure it's the same disease.
Now, so we've got people in the group from all over the world, literally, and some hospitals only have limited resources and don't offer all these range of treatments.
No, absolutely.
So someone who's only offered chemo, no trials, should they really seek out a second opinion at a larger hospital?
Well, I mean, I think that what we know is that chemotherapy alone is less effective than chemotherapy plus rituximab.
Right.
And I accept that in many parts of the world, rituximab is too expensive, not available. But I think antibody therapy is very important in keeping this disease under control. But one is, of course, aware of huge disparities in wealth. And the advantage of information technology is everyone around the world is aware of what can be done. But it doesn't give them a clean water supply, and it doesn't necessarily give them antibodies therapies or modern anti-cancer therapies. So I think it's very unfortunate if patients can't get access to the most modern anti-cancer therapy. And we would hope that chemotherapy plus rituximab will be available in many parts of the world.
Okay. Why are some people following up with radiotherapy and some not? What's the reason and expectation when you use radiotherapy afterwards?
Well, radiotherapy is very good for localized disease. It controls localized disease very well. And furthermore, this is quite a radiosensitive tumor. You don't need to give huge doses of radiotherapy. And if patients have had what's called bulky disease, large tumor masses, and they've not gone away completely, or there's a suspicion that there's a small amount of tumor still left, then I think it's reasonable to offer radiation therapy after chemotherapy, or sometimes as a single sole therapy if the disease is strictly localized to one place and is causing symptoms.
Okay. Somebody's asking a question, is it common for patients to have bronchial issues after rituximab?
It's not uncommon,
yeah.
And I think this is another reason for considering whether or not maintenance is beneficial. So if patients start to get multiple chest infections, or they start to get sinus infections, especially when allied to a reduction in their own immunity, that's when we consider whether or not you should continue.
Okay. Lots of question around, is it cladribine?
Cladribine.
Yes. Why does the research seem to be slow, though, or has it even been dropped?
It has been dropped, actually. Interestingly, there's what's called purine analogues, such as fludarabine and cladribine. There was a fair amount of interest in them a decade ago. The concerns about fludarabine in follicular lymphoma associated with long-term effects on the bone marrow And cladribine, though it's an effective drug, has fallen out of favour somewhat in favour of bendamustine and of CHOP in first-line usage.
Okay.
It's very useful, though, in an allied disease called hairy cell leukemia, where it remains the standard of care.
Okay. Do regular GCSF injections make the bone marrow lazy?
No, they don't, but you have to consider why you're giving it. If you're giving it only after chemotherapy to try to boost the white cells which have been suppressed by chemotherapy, that's a good thing. Most people with follicular lymphoma do not require long-term GCSF, and there's no evidence that short-term usage is anyway detrimental.
Cool. Second to last question.
Oh, right.
We've gone through a lot of questions,
yes.
about 50. Do you recommend IVIG for treating neutropenia?
Not for neutropenia, no. For persistent neutropenic sepsis, allied to a reduction in immunoglobulin levels, there is an indication. So if patients have got reduced immunoglobulins due to either treatment or if it's pre-existing, and they start to get infections, that combination is important. You don't treat the isolated reduction in immunoglobulin or isolated infections, but the combination of low levels of immunoglobulin allied to an increased risk of severe bacterial infection will be an indication for giving long-term immunoglobulin.
Okay. So my final question is around, there's 1,800 people in this group. There'll be a couple more thousand by the end of the year, I'm sure. What's the one piece of advice you would have for someone either with the, finding out they've got the disease for the first time, or for those that maybe have been on watch and wait for a while?
I think the important thing here is to maintain a high level of hope that this disease can be controlled in the long term. Don't jump into therapy because there's no immediate need to do so. This is a fairly forgiving disease. We always talk about, you have to detect cancer early, and when it spreads, it's not treatable. That doesn't seem to apply to follicular lymphoma. It's nearly always widespread when it's diagnosed, and the harder you look, the more you find areas in the bone marrow or elsewhere. So there's no need to treat this if it doesn't need treating. And ensure that either you're going to go into a clinical trial or the centre that's treating is aware of such clinical trials and is appropriately up to date. That's much easier now as a consequence of access to information electronically than it used to be, but it's still very important that patients get appropriate advice and are well informed.
Brilliant. Dr. Robert Marcus, I could not be more thrilled that you've come here today and shared your wisdom and expertise with all of us. Really makes a difference, so big thank you.
No, it's a great pleasure to be here. Thank you very much.
Thank you.